I need to tell you about something that frustrates both patients and physical therapists. You've got someone who's done everything right. They've gone to physical therapy, they've done their exercises, they've corrected their ergonomics, and their pain isn't getting better. In fact, sometimes it's getting worse. What's happening here is that their pain has moved beyond just a physical problem into something more complex, and we need to talk about the biopsychosocial model of chronic pain. Chronic pain isn't just about tissue damage anymore. Research over the past few decades has made this very clear. You've got biological factors, sure, the actual tissue damage, inflammation, structural problems. But you've also got psychological factors like catastrophizing, where someone assumes the worst-case scenario about their pain, fear avoidance behaviors where they stop doing activities because they're afraid of making things worse, and comorbid depression or anxiety. Then there are social factors, the work environment, whether colleagues are supportive, even compensation systems that might inadvertently incentivize remaining in pain, for office workers specifically. There are some really important psychological components we need to screen for. There's job strain, which is this combination of high demands and low control over your work. That directly correlates with musculoskeletal pain in the research. There's workplace conflict or bullying that can manifest as physical symptoms. And sometimes, though this is uncomfortable to acknowledge, there are secondary gain issues where the pain provides an escape from a job someone hates. The screening tools exist. The pain catastrophizing scale can identify negative thought patterns. The fear avoidance beliefs questionnaire reveals when someone is restricting activities out of fear. We have depression and anxiety screening that can catch comorbid mental health conditions. But these aren't routinely used in typical physical therapy settings, and that's a gap in care. What really concerns me are the case studies I've seen where someone's chronic pain completely resolved after they changed jobs, despite years of failed physical treatment. Or cases where adding cognitive behavioral therapy for pain, which addresses thought patterns about pain, succeeds where physical therapy alone failed. Or addressing workplace toxicity as an actual pain treatment. The integrated treatment approach needs to include psychological components. Cognitive behavioral therapy for pain doesn't mean the pain is in your head. It means you're addressing the thought patterns and behaviors that amplify pain signals. Stress management training matters because stress directly affects pain perception. Mindfulness-based pain reduction has solid evidence behind it. And sometimes, vocational counseling or job changes are actually medical interventions. Here's what I find troubling. There's often this resistance to acknowledging psychological components because people fear it means their pain isn't real or that they're being dismissed. But the pain is absolutely real. The suffering is real. What we're saying is that the pain has multiple components, and treating only the physical aspect while ignoring psychological and social factors is like trying to fix a three-legged stool by only working on one leg. The healthcare system isn't set up well for this. Insurance often doesn't cover comprehensive psychological pain treatment. There's bias toward surgical or pharmaceutical interventions over behavioral approaches. Getting truly multidisciplinary care is difficult and expensive. But for the patients who aren't responding to physical interventions alone, this biopsychosocial approach might be what actually provides relief.